I'm Dan Wikler. I'm a professor of global health and population at the Harvard School of Public Health, and I am one of 4 people in that department who has a PhD in philosophy. So we're a bit unusual in that way, but the department and the school that I am in has decided that thinking through fairly large-scale, somewhat abstract questions about ethics, about social justice, and some conceptual difficulties involved in population health should be part of the training of public health students, and also can make a contribution to research and to interventions. And I and my colleagues work regularly with colleagues trained in epidemiology and medicine and public health, sometimes to work out some knotty problems in the research that they're doing, and sometimes in service delivery. Each chapter has a team of writers, the lead authors, and 2 people coordinate the work of these, and I'm one of the coordinating lead authors. This is not the kind of work that I ordinarily agree to do. It's kind of visionary, it's a little bit hard to nail down, and the hesitation I had when I first heard about it was that there didn't seem to be any way to assure those of us who were being recruited that we would have a product that would be something other than a bunch of generalities and a lot of hand-waving. Now, I have complete faith in one of the directors, Mark Fleurbet, with whom I've worked for a couple of decades, and it didn't take long for him to convince me that that's not what he had in mind. And when I saw who else was going to be involved, I thought, this is the one time that I should say yes. And so I jumped in. Now, that's not to say that I had any idea what this was about, really. I just had faith that I would one day find out and there would be good news. And having been here now for several days, I think that faith is justified. The scholars here are fascinating people representing very different backgrounds. Everyone has an interesting story to tell, and I think a lot to contribute. And so far, working with the people in our group and with other groups has been very fulfilling, and I think we're going to come up with some useful things. We were given an assignment that, frankly, we didn't understand. The chapter was called The Boundaries of Human Life, and it was a collection of topics ranging from human enhancement and transhumanism, a phrase that nobody quite understands, to questions about the experience of death and dying, and even the treatment of animals. And we puzzled over this, and we thought, what is the subject of which these are all instances? And in the end, we decided to propose to do something different. We saw there was a kind of technological focus to this, and sometimes this is understood as a study of how societies and individuals deal with new technology that has a big impact on important parts of their lives. We decided to take a more population level approach. We are fortunate to have an excellent demographer in the group, and he's made very important contributions to the discussions. The basic message that we would like to amplify is that we have a lot of good news to tell. Because there's been a huge effort on the part of a group of epidemiologists and others over the last several decades to put together a complete map of the experience of illness, of the burden of disease throughout the globe, measuring all deficits from good health and a normal lifespan. And from this research, we're coming to an understanding of the changes in people's lifetime experience of health and disease, and also how long their lives are. And the good news is life is booming. People are living longer, and this is true not just in the wealthiest countries, but even in the poor countries. Now, we usually hear about the problems. We hear about AIDS, which had a terrible impact on some countries that reduced life expectancy down below 40. But that's not the typical pattern, and even with AIDS, there was fortunately an immediate response coming up with antiretroviral therapy, so that in countries like Botswana that have a serious problem with HIV and AIDS, people have a normal lifespan now, or close to it. So it restored what is a general trend, which is a trend toward much, much longer lives and many fewer early deaths. So that's the good news. Now, this is different from all previous generations. The current generation is experiencing, it can have realistic expectations of living longer lifespans than all but a few people could in the past. And moreover, we have the experience of thinking that our peers also will live long, healthy lives, or at least long lives. And this is different too. It changes many things. So it's a piece of good news, but at the same time, it raises questions. For one thing, there are exceptions. There are some populations that are still dying young, and the fact that most of us now are not doing that shows that it's quite possible. It's actually fairly easy to make early death a rarity, and it helps us focus on the cases in which we're not doing that, and sort of puts us to shame. So that's one thing. But also, we have an expansion of how much time we have on this earth to do the things we want to do. Now, sometimes we can do those things. If you want to collect butterflies, you've got many more years to collect butterflies. How about work? Well, if you have a mandatory retirement age, it doesn't matter that you may live 3 decades beyond 65, you still have to retire at 65. But that's a barrier that can give way. And in the United States, actually, it has already. So people are working much longer. The average age of retirement at Harvard, where I work, is, I think, 72. That would not have been true in a previous generation. Then there are other age limits that haven't budged at all, for example, menopause. Now, one very important social change that's occurring not only in the United States and Western Europe, but in many countries of the world, is the entry of women into the workforce and the growing numbers of women in professional roles. Well, to get to those professional roles, you have to educate yourself for a long time. And that's very hard if you have kids. So it would be much easier if you could postpone childbirth until your 30s, maybe in your late 30s or early 40s, if you want to push it. But biology is quite unforgiving. And the fact that there's longer life after menopause doesn't make menopause occur later. Well, what happens then? Well, of course, there's a demand for ways to have children even though you've delayed initial childbirth. And we're seeing that happening with surrogacy, with IVF, with freezing eggs, and so on. And there'll be more and more of this, and more people around the world will demand this, and we'll get it. So we're uncoupling age-old patterns of the timing of stages of life with the timing of initial childbirth. That's a profound change. It will affect the parents, the children, and all of society. And we want to spell out some of the repercussions of this. Now, this is a trend that's not occurring at the same pace everywhere, of course. In the richest countries, it's much more advanced. And one of the ways that people in the richest countries deal with the biological problems, in some cases, is through surrogacy contracts with people in poor countries. So it's the inequality that's enabling the people in the wealthiest countries to accomplish this. Now, what we expect is that people in what are now the poorest countries will, in time, adopt many of the same practices. And of course, eventually you'll run out of people who are poor. So you're not going to use surrogacy if surrogacy requires an impoverished person who you can make a contract with. But there will be other ways too. So our chapter is going to be about the changes that occur in the texture of life, the experience of the great certainties of birth, reproduction, work, childbirth, bearing children, aging, disability, death, that are already changing in unheard of ways, sometimes on a radical scale, for a fairly privileged minority of humans, but which will in time extend throughout the entire world. I've worked a lot on a set of ethical issues in global health and population health that are ethically urgent, I think, but don't involve individual choices. They involve social choices. The ultimate impact is on individuals, which is why they're ethically important. But questions are not questions we ask individuals to confront or make decisions about. Let me give an example that's relevant to the chapter that we're writing. With increasing lifespans, something that's really wonderful, there's also been a trend toward much lower fertility throughout the world. In the 30s, 40s, and early 50s, there was tremendous anxiety, especially among the elites in the richest countries, about overpopulation. Now, you weren't supposed to say this, but they were especially concerned about overpopulation among those people, not us, but them. So that's when we got these population control programs. And there was almost hysteria at one point about the globe being overrun with billions and billions of people that it couldn't support. No one saw what was going to come, which was a worldwide decline in fertility. Even in countries where the norm had been to have 7, 8, 9 children, now suddenly women were having 2 or 3 children. And in some cases, so few children that they were dropping below the replacement ratio. So you have the prospect of declining populations. So we have lengthening lifespans, but declining numbers of young people. Now, one thing that's happened with the increasing lifespan is that the number of years of life lived with a disability is not going down at the same rate as the death rates. More people are alive longer, but more of those years or many of those years are spent living with a disability. And if the disability is a severe handicap, then the person becomes dependent. Now, when an aged person becomes dependent, who takes care of that person? In some countries, you have social institutions, old age homes and so on. But in many countries, especially the most populous ones, there's no such system. So that means that somebody else has to take care of them. Who is it? It's someone within the household. Typically, it is a girl who will be taken out of school or taken out of the labor force to take care of aged grandma. When you had 16 children to take care of one grandma, the burden could be divided among them. But now the ratio has been inverted. You have the inversion of the population pyramid, and there may be 4 grandparents and 1 grandchild. What happens to that if there's a girl available? What happens to her? The entirety of that burden is placed on this one person, and she isn't chosen at random. She's chosen because she's a young girl. Now, looked at this way, this is profoundly unjust. You have these 2 massive, large-scale population trends of longer lives, higher rates of disability among the aged, and then fewer young people to take care of them. But only one small group is chosen because of cultural traditions. One small group is chosen to bear that burden. This is profoundly unjust. And it won't do, that's all. First of all, it's not adequate to the task, even if you took every single one of these people and put them to work at this. But in trying to do that, meanwhile, you've stunted the opportunities for advancement and escape from poverty in many cases for a huge number of people who happen to fit that demographic description of being a young girl available to the household. What do you do about it? Well, a decade or so ago, when I was at the World Health Organization, I teamed up with the director of long-term care, who had done a study of the burden of disease data that had come in for epidemiological purposes in order to look downstream and see where these dependency ratios were going to be at their peak in which countries. And we found that some of the most populous countries in the world were approaching these within the next 2 or 3 decades. And this was not a matter of maybe. The people were already alive. This is definitely going to happen. And we began to organize an effort to try to rethink this pattern that we've always depended on about who takes care of the dependent aged parent. Now, that pattern, as I've said, is one thing when you have a lot of grandchildren and only a very few grandparents who've lived long enough to become dependents for a number of years. Those facts are no longer there, but the cultural pattern remains. And we wanted to encourage people and societies to rethink this. Now, what we quickly found out that we were now coming up against some of the most ingrained patterns of traditional culture. And so a common response to our questions was, well, that's how we do things here. And this is everybody's understanding of how you do things here. Well, all we can say is, you are on a boat approaching a waterfall, and you're seated in the wrong direction. You're looking back, and you're going to go over that waterfall, and you have to do something. What do you do? Well, it looked to us as though you have to rethink some of these traditional mores. Now, they're guarded in some cases by religious authorities. Well, they have to rethink these traditional mores. It's not something you usually suggest in these forums. It's usually you defer and you respect tradition, especially traditional sources of morality and customs. But when it's highly dysfunctional to do that, and we thought this is a good case of it, and highly unjust, we also thought, we hoped we could spark something. Now, we failed. And for a variety of reasons, we didn't have the means to do it. Maybe in this chapter, this is not our major theme, but it's an example of the ways that large-scale changes on population scale, with longevity and fertility and so on, can have an impact on the texture of everyday life and raise questions that must be faced by society in order to achieve a just society. And I'm hoping that we can help to light a fire under some of the society to debate some of these issues.